Opto TV, the first web channel dedicated to ophthalmology. A new web series is starting. Let's welcome our guest. I welcome you, Doctor, to the new episode of Opto TV.
Thank you very much, Mr. Papanikolaou.
Our today's guest is Dr. Dimitrios Besinis. He's a glaucoma surgeon trained in Western Eye Hospital of Imperial College in London. He received his PhD at the University of Athens, and currently he has his own private practice in New Smyrni in Athens. He is also the glaucoma lead of eye clinic in Papandi in Athens, Greece. So, we can start very simple, doctor. My first question is, what is glaucoma?
Glaucoma is a group of diseases that share some common characteristics that lead to programmed cell death of ganglion cells, causing nerve fiber loss and optic nerve degeneration. This degeneration causes irreversible visual field defects. Most of the times, glaucoma is present with high intraocular pressure. There are cases of glaucoma, though, that the pressure is within normal limits. Therefore, normal readings of intraocular pressure do not exclude the presence of glaucoma, and high intraocular pressure does not confirm the disease.
Having understand exactly what is glaucoma, I'm coming to the second question. What is the treatment of glaucoma, Dr. Besinis?
By treating glaucoma, we aim to stabilize the disease and stop progression. In certain cases where this is not possible, we aim to minimize the rate of progression, preserving vision in a patient's lifetime. The only known factor that can be modified to stop progression is the intraocular pressure. This far, lowering intraocular pressure is the only way to treat glaucoma and stop vision loss. The type of glaucoma and the stage of the disease are two factors that determine how low the intraocular pressure should be. Most of the times, this is patient-specific, meaning that different eyes and patients can handle different levels of intraocular pressure.
As it looks, intraocular pressure is the target. So, what ways do we have to lower the intraocular pressure?
Lowering intraocular pressure and treating glaucoma can be done with three different ways. First of all, with the use of drops, which was until recently the treatment of choice for newly diagnosed patients. Other ways include the use of lasers and surgical procedures. In some cases, we may combine the above strategies to achieve adequate pressure and glaucoma control. Glaucoma is a potentially blinding condition which must be treated early and must be treated aggressively. Think of glaucoma as a race against time. We all lose nerve fibers as we age. People with glaucoma lose them faster with an increased risk of permanent vision loss within their lifetime.
Dr. Besinis, you mentioned that until now, drops was the initial treatment of choice. What do recent studies show?
Recently, LIGHT trial was published. The aim of the LIGHT study was to compare the use of drops and selective laser trabeculoplasty as initial treatment in patients with newly diagnosed mild to moderate open-angle glaucoma or ocular hypertension. In the 3 years of the patient's follow-up, the LIGHT trial showed that 74% of patients in the SLT group were drop-free. This means that in 74% of patients receiving SLT as primary treatment, their condition was controlled without drops in 3 years. LIGHT study is also expected to publish the 5-year results. The LIGHT trial is a very well-designed study that was included in 2020 European Glaucoma Society guidelines. More specifically, EGS mentions that newly diagnosed patients with mild to moderate open-angle glaucoma or ocular hypertension should be offered SLT as primary treatment.
I have to ask because now my next question, it's a little bit difficult for me also to pronounce or to say exactly the word, but what is the laser trabeculoplasty and how does it work? Can you please explain me? Much easier.
Laser trabeculoplasty has been present in glaucoma treatment since the 70s. Weiss and Witter published the first study in 1979 about argon laser trabeculoplasty. The evolution of ALT is the selective laser trabeculoplasty, which was developed by Mark Latina and approved by FDA in 2001. Compared to ALT, SLT selectively targets pigmented cells within the trabecular meshwork with the use of a 532 nanometer YAG laser. With this way, there is no thermal damage in the trabeculum. SLT is equally effective with ALT, with some important advantages. The energy in SLT is lower, the damage in adjacent tissues is minimal, and more importantly, it can be repeated. Compared to ALT, SLT can be safely done more than once. Even though we don't know exactly how SLT works, it has been hypothesized that there are cellular, mechanical, and biochemical modifications in the trabecular meshwork that have an IOP lowering effect.
Having all these informations concentrated and all these important guidelines, what you have already mentioned, I'm coming to my last question. What or who, better, is the right patients to be treated with SLT?
As I mentioned before, SLT is a very good option for the early stages of glaucoma. A patient with a newly diagnosed mild to moderate open-angle glaucoma or ocular hypertension should be offered SLT as first-line treatment. There are a lot of studies about SLT showing that it is effective in primary open-angle glaucoma, in normal tension glaucoma, and even in pseudoexfoliative glaucoma, which is quite common in Greece. Even if someone has had cataract surgery, does not change the IOP lowering effect of SLT. However, we must be careful in pigmentary glaucoma, where SLT can cause IOP spikes and even permanent increase of intraocular pressure. In these cases, it is best if SLT is performed by a trained glaucoma specialist. There are also indications that SLT is slightly less effective in patients already on prostaglandin analogs. Taking all those into account, the ideal patient for SLT is a newly diagnosed patient with mild to moderate open-angle glaucoma or ocular hypertension who is not under any drops.
This was another interesting episode from Opto TV. Until the next time, stay tuned. Thank you for watching us.